Hello and welcome to Women's Football Hub. I am your host for this episode. I am Carolyn Kent, and today we're going to be talking about keeping players active through pregnancy and then returning them to play postpartum. And I am delighted to say that I have a returning guest today in Dr Sinead Dufour, who has been working with the FIFA expert panel looking at all of this new research, and that's something we're going to take a deep dive into today. Sinead, welcome back.
Hi, Carolyn. Thank you so much for having me back. I'm really looking forward to speaking with you today.
Hey, I'm just really delighted I could get a couple of minutes in your diary because I recognize that after all the research you have been involved with, you will be a very busy woman. So let's deep dive in straight away. Let's talk about what you've been working on because you have been putting in a power of work with a lot of other people, haven't you?
Yeah, absolutely. So, when I was on the podcast last time, we were really just getting close to publishing some of our kind of overview reviews, really. And so, we did a big overview of the literature on pregnancy in football and then postpartum in football. And really, part of that was just to get a sense of the state of the science on both of those areas and really figure out what do we actually know that is different than what's happening in practice and what don't we know? Like, where are there some gaps? And then from there, it was a matter of saying, okay, so with what we know and with where the gaps are, let's actually conduct some research right now to try to fill some of the gaps, map out a research plan of later research to fill out more of the gaps. But actually, we do know quite a bit. And what we do know now actually does not support generally what's been happening, which is ultra conservative and actually not supporting perinatal players to play. And so, how can we actually create really rigorous decision aids to support players and their MDT and support network to keep them in play and to really make safe and appropriate decisions that are specific to them, given the knowledge that we do have? So, creating these decision aids, as you can imagine, was a massive undertaking. It took us really years to actually do this, but they have literally both just been released together with a learning center from FIFA, which we all contributed as faculty to these education modules. And very much some of that education on the learning center, which is free to access, really actually enables folks to carry out and administer this decision aid. So everything we've been doing has been moving towards trying to get these decision aids going, and those have essentially just been released, which is very exciting. It feels really good to be at this point finally.
So let's talk about that decision aid. If you had a new sort of younger practitioner that was going, oh my God, if players come to me and said they're either thinking of getting pregnant or they are pregnant, how would you advise them to use this decision aid?
Yeah, so absolutely. So it's quite nice that it maps things out. It's quite a clearly mapped out process. And essentially, we would say teams should really just use the age aid and follow it along kind of step by step. So the first step really is all around profiling the player because the individual context of the player, their environment is so important in terms of then what decisions are being made, right? So the first section is all about actually profiling the player. And then the second section is about really determining are there actual contraindications? So if we're talking about the pregnancy context here, are there actual contraindications to vigorous exercise or football? Because, of course, there can be. While on one side, we really want to be flipping the script and saying, what are the risks of pulling people unnecessarily out of exercise and activity? And there are many. But we do recognize that pregnancy impacts every single biological system. Each person is a bit different. And there can be times where there might be something going on medically that it might not be appropriate to carry on. And so that second part of the decision aid is really about contraindications. So we've used the Get Active in Pregnancy questionnaire. This was developed by Dr. Margie Davenport and her team in the University of Alberta. And that is actually a newer tool. And it's quite a rigorous tool to make you feel very confident that if kind of something shows up on there, that's been flagged as a contraindication. And that doesn't necessarily mean stop per se, but it means stop as far as the football support is concerned, and the individual needs to talk to their medical provider. And then the next step after that is looking at considerations, not contraindications, but considerations for this particular athlete. And within the considerations, there are 3 actual screening tools that are part of it because they teased out as the most important considerations. The first one is mental health, and it's using the Edinburgh perinatal mental health scale. The second one is fear of movement, because fear of movement comes across so profoundly that when we even think of anything like pregnancy-related pelvic girdle pain, really it links very closely to musculoskeletal pain in athletes across the board, but it teases out so clearly as an important contributor and trigger for pregnancy-related low back and pelvic girdle pain. So fear of movement is on there. And then, of course, pelvic health screening. So that's on there as well, using the pelvic floor dysfunctional sentinel scale. It's a nice, very fast 5-item tool. So we have that as our main screening for considerations. And then there are also a list of other considerations that are really important, but didn't tease out as clearly a priority to have its own screening tool. So things like sleep, energy, those types of things. And then after that, and with each of these, we're doing the screening tools, we're checking things off. And this is giving us information then on how we might make decisions. And then, of course, the last part of it is really looking at the stepwise progression or regression. So once we have all that big kind of upfront backdrop, then it's a matter of, okay, is this individual sort of appropriate for our baseline level, which is some individualized training? Are they at the point that they're actually appropriate to train with their team, but not engage actually in any play, and so on? So we have this 5-step sequence that we have developed rigorous criteria for each one that dictates, can you move up or down these 5 steps? So nothing about the decision aid has anything to do with timelines. That's something that makes this tool very different than tools in the past that were indicating, look, if you're in the first trimester, these are all the rules. Second trimester, these are all the rules. We're saying, nope, you could have a player in the first trimester doing things that historically you would have imagined someone more doing in the second trimester or third trimester, and vice versa. Everything is very unique and individualized to that player's context. So you have that last bit. And then the other part of the decision aid, we've embedded a communication tool. That's really important. So everyone on the team is all on the same page, speaking the same language. So it's a communication tool that's baked right into the process of the decision aid. So really and truly, there's a pregnant player, you want to support them rather than being really freaked out, like, now what do we do? Because this is something we've heard for years and years, which is why we needed to develop these aids. There can be confidence of a really clear, evidence-based tool that you can walk through step by step and actually support that player within their kind of own unique individual context.
So basically, key take home here is we're no longer time led. And you've got lots of decisions that you
100%.
can look at. So I think that's probably a big thing. Now, there'll be some people that are obviously very well supported, have a multidisciplinary team around them. And in your paper, Pregnant Pitches, it basically spoke about the multidisciplinary team. What does an ideal multidisciplinary team look like for a pregnant footballer?
Yeah, you're quite right. We have scenarios where someone might have a team of 10 and you have the ideal, and others where it's 2. And to be fair, as we developed the decision aids, that was very front and center on our mind. So to be fair, it is designed that even that MDT of 2 people can really be empowered to still really do much more support, even just in that team of 2 than they would have otherwise, right? But in a perfect world, when we think about the different domains of what seems to be really important through this perinatal care period, pelvic health, for example, is something that really comes through. So in a perfect world, if there is access, to someone with pelvic health expertise. Most of the research in this really does showcase physiotherapists with specialization in this, but it doesn't necessarily have to be a physiotherapist. Emma Brockwell, she is on my FIFA perinatal team, and she is a pelvic health physiotherapist for 5 of the teams in the Women's Super League. And so, in ways, that would be the ideal to have access to someone like Emma with her skill set. And if that's not an option, someone like Emma or even myself or another pelvic health physiotherapist by virtual care consultation. Even we
Yeah.
have a lot of data showing that virtual care for pelvic health for people who are really well experienced, have good pattern recognition, can be very useful. So pelvic health for sure is one that would be really useful to have. Another one, as I said, that kind of comes up is the mental health piece, the fear of movement, some of those kind of psychological kind of constructs that can be really important. So ideally having someone who has good expertise on that side of things. Nutrition is really important because even a lot of the research that we ended up doing to kind of fill in some of the gaps before we finalized our decision aids highlighted actually the issues of REDS and the previous history of REDS actually having impacts on births and more adverse events through birth. And these were findings we weren't even expecting to find. So the point is that we know that REDS and any issues with low energy availability and inadequate fueling for the demands you have, we know that's an issue for female sport. It's an issue actually for all athletes. And we also know that there are just way more demands on actually running the physiology of a person who's pregnant. And so it becomes something that's even more important to really look at is the nutrition and the fueling and the energy availability. So that nutrition piece is really important. And then on that same topic of kind of energy, because yes, fueling's part of it, but also charging your systems with really good sleep and adequate rest and kind of some of those pieces. So having someone who really is kind of has some expertise in that sort of recovery and recharge perspective of things becomes very important through this period. So that's just an example of a couple other providers or support folks that would be ideal when you have perinatal players, ideally.
Yeah. And I think it's interesting because I'll come on to nutrition in a bit because I was on your kind of FIFA Female Health Project. I was doing a little bit on there and it was talking about the amount of calories that are actually needed when someone is breastfeeding. So that's something I'll come on to when we come on to the second paper, which is kicking off motherhood. But just to finish off this section, right? One of the big things that practitioners are going to add, and again, I'm going to stress, we're now no longer time-led, we're decision-led. They're going to talk about what practical adjustments do we make in training and match and when can what about contact and what about safety? Those are all the questions that if somebody's never been through this before, even
Mhm.
with the decision aid, they're going to be like, oh, and there's a nervousness. And I think that probably comes back to you talked about the psychosocial stigma
Mhm.
surround pregnancy, right?
Yeah.
So what do you have advice for people that are maybe going through this for the first time and they're like, look, or what have you seen kind of practitioners have been doing who are working with pregnant athletes?
Yeah, absolutely. So this is a great point, and the decision aid is actually so helpful for this. So you're quite right. We have kind of operated under this stigma of you're pregnant. This means we need to be super, super careful and ultra conservative. And actually, what our research shows is there is very predictable risk with unnecessarily pulling people out of training. So the degree of risk, even when we think of like the classic hypertension in pregnancy, like preeclampsia, gestational diabetes, the amount that we can mitigate those issues and optimize physiology is huge just through exercise. The amount of mental health we can preserve and optimize by keeping people with their team and with their group and kind of training and connected is huge. So, really, the question has to be what risk are we doing by unnecessarily pulling people out, right? So, it's almost like that kind of has to be the script that we're flipping, right? When it comes to some of those nuanced things like, yeah, but contact, yeah, but some of these other pieces, These are very valid concerns, right? Up to now, we have had the perspective of when we're in the first trimester, the uterus isn't going up and beyond that sort of pubic bone or that symphysis pubis. It's protected and tucked under. So we feel like there's a degree of mitigation of risk from that perspective. But then when we're on that, given the anatomical changes, now we're in a risky situation. And really, again, we did data to explore this issue of contact and to see, okay, given that the current guidance, it's very conservative and it's really quite theoretical at best, what are players actually doing? And we found that players actually were still just carrying on, doing their best to mitigate their own risk, but still participating in contact. And we were able to deduce if we look at the risk from 2 hard blows versus 1 hard blow and calculating it all in the research, we actually found there wasn't any risk. And so, what we have done now with that insight is to say, okay, we still acknowledge there's going to probably be certain sports organizations that still upheld their own regulation, no contact beyond that first trimester. And I think it will take a while and decades of really rigorous research until something like that changes. But what we've mapped out in our sort of guidance is forms of more modified contact.
Yeah.
So again, like when you think about the how to, like how do you actually modify? What does it actually look like? This is where when you access our decision aids, and they are open access papers, and FIFA has now produced playbooks about each of them that really almost are a little bit more about the application and how you would administer it. So almost more practical than looking at the actual research paper. But if you were looking at the research papers and they are open access, it's the supplementary information. It's a supplementary file that you have to go into, and it literally takes you through the how to. Like, how might you modify if this is where your athlete is at? These are the tests you might run to gain more insight. So, let's say where they're at in their pregnancy, you're not sure how well they're managing intra-abdominal pressure. We've put in, for example, do the active straight leg raise test. This is how you do it. This is how you interpret it. If this is what the score is, these are some ways you could adapt to get a better movement output. So it literally is giving you that nuance and suggestions and options for all different domains of conditioning, strengthening, flexibility. It maps through all of it. So it very much is a how to, that very practical how to. What measures am I going to use? What little tests am I going to use? How am I to interpret that? What are all my options for now modifying the movement strategy? It's all mapped out there.
Yeah, and it's great to hear that practitioners are going to be supported with that because I think that'll give them a lot of confidence actually. Now, coming on to the next paper, kicking off motherhood, go into kind of postpartum phase, you emphasize and bring up the concept of the fourth trimester. Let's
Yeah.
just chat about that a little bit, what that means and what people should be looking at and thinking about in that sort of space.
Absolutely. So the fourth trimester is a concept that I would say, even over the last 5 years, has finally started to permeate a little bit more. So I would say, even up to about 5 years ago, really the thinking was you birth your baby and then it's all about that first 6 weeks and then you get your clearance and then off you go. And that's more how people thought about postpartum. Your first 6 weeks is the one phase of it, and then 6 weeks and beyond is the other phase of it. And actually, the data is quite clear that the first 13 weeks after you have your baby really should be considered in ways as a trimester, just like the 3 trimesters you have when you're growing your baby in utero, because so much development and so much co regulation between mom and baby is still happening and arguably should be protected and supported for the benefit of mom and her overall sort of wellness and baby. So it's a matter of thinking of it from that perspective, but also acknowledging, yeah, it's this whole first 13 weeks that we're getting a lot of recovery, a lot of change. Even if we think about for those moms who are really exclusively breastfeeding or breastfeeding quite a bit, it takes, and so it takes time. So we can feel a little bit more confident that there's a degree of more physiologic ability after that fourth trimester, right? And so that's really important. And that's not to say, so even when we think of the return to running guidelines, because before we came on, you and I were chatting about that briefly. And of course, those kind of came out and they were groundbreaking at the time, because even before then, there was nothing to guide any of us. But really, the consensus from that work was, yeah, we got to protect this fourth trimester and probably this high impact activity and running. Most people probably aren't going to be ready structurally, physiologically, and so on until they're out of that phase. It's possible some people could, but most people won't. And so, really, that's more where that comes from. And so, we've punctuated that in our review paper. That having been said, when it comes to the guideline, which is the step back into play guideline, because it's a postpartum, it essentially follows the same sort of steps as the pregnancy one, although the progression, rather than being 5 steps, is 7 steps, right? It's a little bit broader. There's more steps that you can progress and regress, and it is all timelined. So it isn't structured that, nope, you can't do anything until after the fourth trimester. It still is timelined. You still might have one player that literally in the postpartum at 4 weeks is on step 2. You might have someone else who's 16 weeks and still on step 1. So it still is completely focused on the player. But we do, through all of our work, we showcase and reiterate the importance of thinking about this kind of fourth trimester, because it is a different time physiologically for mom and baby. And there is a lot of recovery happening that doesn't just stop at that 6 weeks. It's happening over the course of those 13 weeks.
Yeah, and it's interesting because we also spoke before we came on. I was telling you about the kind of few female athletes that I've worked with. They've come back and they've stepped back into play. And I've definitely noticed a hyperlordosis with many of them.
Yeah.
Biomechanical advantage?
Yeah,
Protected?
absolutely. So this is something that I often include in my teaching because, of course, one of my other areas of interest is pregnancy-related pelvic girdle pain. And of course, it had been previously thought that this like excessive lordosis was actually one of the reasons why these folks were having pain, and therefore we should try to straighten the back out and fix it and whatnot. But actually, we're looking at things much more holistically now rather than being stuck in this biomechanical sort of myopic lens. And we can actually see and understand that no, it's a beautiful, intelligent design of the body that, and I think especially for athletes, as you are now loading a lot more through your pelvis that has way more weight because you're carrying a baby, the structures have changed a little bit. By you having more lordosis, it actually puts your symphysis pubis actually more in that sort of caudal direction. So you actually have a lot more structural support for the weight of everything above. And for that to slowly migrate its way back to where it was before in a slow fashion, which over time we do see, it makes sense because those tissues still need time to recover. And so you have now the protection more of like the bony architecture kind of protecting. So it really is quite an intelligent design. The body and the ability to adapt through pregnancy and postpartum is amazing. And we're seeing some athletes coming back and having personal bests after they've had their babies now, right? So it really does show you that with the right guidance and permission, and yes, looking at all of the things and having a roadmap to follow, it's allowing these athletes to do a lot more. We've had a chance to hear from different groups who have said to us, oh my goodness, we had a pregnant player before these were available. And one, we were really scared. The player was scared, right? Didn't really know what to do. And now just all of us feel so empowered to collaborate. We actually have something to hold on to and guide us to navigate around. So it's been really exciting. And really, I think we're just at the beginning.
Yeah, and physiological advantages of actually having been pregnant. Your paper actually makes some references towards that as well, that actually there might be advantages to having been pregnant. Can you expand on that just a little bit?
Yeah, absolutely. So even when we think of I guess we can almost call it the learning that the system kind of has to go through, almost like developing some of that physiological wisdom, that wisdom for adaptation, there's no time that pushes that more than in pregnancy. So even if we use the example of birth, right? So those of us who work with pregnant folks, we've seen that a lot of the times the way the first birth goes takes a lot longer, labors are longer. Everyone's a bit different, but when we're netting it out across the board, this is a very consistent trend. And then very consistently, second time around, births are always faster, smoother. And we know it's because the system now, it's done this massive collaboration before. It's done it before. It's developed this wisdom to know how to do this, and it clicks and it does it. So when we've actually pushed some of those adaptations in every system to the edge, the systems, oh, I've done this before. Oh, I actually have capacity to adapt like this. So we open up that opportunity window. And this is why I think we are seeing people almost being able to have this new level of opportunity open to them, but they do require a ton of support to take advantage of that, right? Because even coming back to the point you had mentioned before about nutrition and pregnancy, you're
Mhm.
quite right. With postpartum, with breastfeeding, it is such a metabolically demanding activity. And it is equivalent to doing a running race every day. It is huge demands. It comes with a ton of amazing health benefits too, though, for mom and co-regulation of baby. But it's something that we need to consider for
Mhm.
an individual who has that much additional tax on their metabolic system and their energy system. We need to make up for that, right? So, yes, there is so much opportunity, but there is a ton of support that's needed, right? So that's the thing. We have these decision aids out now, but to be fair, to actually implement them well, it requires a lot of support, requires a lot of basic education, which is why it's so critical that while we were developing these, at the same time, we were developing the free education on the FIFA Education Center, because most NDTs, especially if it's a really small one, they're not going to know enough about each of these topics to then really be able to use the decision aids to its maximal capacity. So having both of these pieces is really important.
And there's also the element, if you haven't seen somebody who's been pregnant going through this process, being confident as a practitioner is quite, even when you've got all the resources there, it's still difficult, which is why a virtual consultation with somebody who's a FIFA expert would be a great idea. So
Yes, 100%, 100%. And that really is, yes, there is the training center, but the way FIFA has structured a bunch of us into other kind of working groups, they've done that to say, okay, there might be a time when there's a club that now they have a pregnant player and they actually need to kind of get some expertise, specifically just helping them like
yeah.
temporarily in certain areas. So I do give FIFA a ton of credit for investing into this really important priority.
I'm loving the concept of the virtual MDT. I really am. I'm loving it. Like
Yeah.
now, the other thing that the review went into, and this was something that I picked up on, and I've seen this as well, is there are some common postpartum issues that can sometimes creep up. So let's talk about iron deficiency and also
Mhm.
anemia. So let's talk about
Yeah.
those two things. How do clubs or a practitioner who's working with a player, how do they recognize it? And then what's the place where they go to in order to help with that?
Yeah, absolutely. So this is where sometimes the postpartum period can be tricky because you can have a symptom like anemia, iron deficiency, but sometimes that actually looks like depression. Sometimes that actually just looks like fatigue. And if mom is breastfeeding and sleep is really dodgy, and it can be easy to overlook these things. But anemia is really common. And so that's why it's one of those things that we have flagged and we talk about a lot to try to prevent an issue like that from getting missed, because it is a
Mhm.
fairly straightforward thing to treat. If we can just get the ferritin levels back up, then things are a lot better. So again, this is part of why we have the screening. We have the depression screen, but even if things come through on the depression screen, it doesn't necessarily mean this is an issue that requires a psychologist or a psychotherapist per se. It's just showing us something is off in the system that needs support. So even something like the depression screen, there can be from there thinking, okay, how are we going to tease this out more? Is there a nutritional deficiency like iron deficiency? Because there can be other deficiencies that also show up as depression, like B12 and other things, right? So this is one of the reasons why we have some screening like that. And it's why in our biopsychosocial considerations, we're also flagging around the sleep, the breastfeeding, et cetera. Because if sleep is good, person's not breastfeeding, whatnot, but they have this crazy fatigue, it really is pointing to there's something off. So if there is ever the slightest worry through triangulation of all these factors, that there is something off, like anemia, this is more of a medical thing. This kind of now is going back to medical. Yeah.
Yeah. And it's, I suppose it's checking the bloods and, and checking that the systems are
Absolutely.
happy.
And then medical will need to check the bloods and see. Yeah.
Yeah, exactly. Now, my final question, because I could talk to you all day, but I know you're a very busy woman and you've got up very early to come and talk on this podcast and you've got a busy day. So let's talk about, you discussed cesarean versus vaginal deliveries and then having potential different recovery timelines within that paper.
Yeah, absolutely. So it's to acknowledge a cesarean birth is a major abdominal surgery, right? So it's to acknowledge that right out of the gate. But it's also to acknowledge, and this is why we talked about different modes of birth, because it is important to think of. It's not good enough to just say, okay, this is pregnancy and then this is postpartum, because the different context of how the birth went down has a lot of implications now for the postpartum that we need to consider, right? So, cesarean birth, abdominal surgery. But within the context of cesarean birth, we also have an elective cesarean and an emergency cesarean because the attempt was vaginal, it didn't go through. And those two categories of cesarean have actually very different outcomes. And even those are things we have to think about. So, yes, there are the usual sort of tissue things. Now we have the scar tissue that we have to deal with. We want to make sure that we are addressing the scar tissue because if we don't, there are implications for the abdominal wall. Cesarean birth is an independent risk factor for diastasis rectus abdominis persisting in the postpartum. And that's a problem for a lot of women cosmetically and functionally. But that's a problem for athletes because it is a functional muscle performance problem if we don't get good activation and load transfer through the abdominal wall, right? So yes, there are those pieces, but generally births that kind of end up going to cesarean that were not planned, we see that there's a very different sort of mental health and slower recovery profile that goes hand in hand with that. So that's something we want to think about. For vaginal births that have a surgical or medical assistant component to them, we also see have additional implications. So for example, if there are more degrees of tearing or episiotomy was used, vacuum forceps, that goes hand in hand with the risk profile for more severe incontinence, for fecal incontinence, and for pelvic organ prolapse versus a vaginal birth that didn't have those things. And so it's not to say every single person in each category, we can assume they're going to be the same. No, but there certainly are trends and there certainly are considerations for someone who had a vaginal birth, but with a lot of medical assistance. We would really want to be extra attentive kind of on the pelvic health side of things. For example, someone like that, someone who had a cesarean birth that wasn't planned, it was emergency. We really want to be thinking of trauma, psychological health in a really sensitive way with someone like that, for example. Yes, there are actually the tissue things, like the diastasis is something really important we want to think about in abdominal wall rehab for a cesarean. But it's also that other context, which is why, again, in our decision aids, nothing is on a timeline. Nothing is on a timeline because you can have someone who had a planned C-section who actually has quite a bit of support. They're kind of getting onto it and they're actually ready to move along things even gently at 4 weeks. You can have someone else, it's an unplanned C-section and it is a year later and they are still not ready. And so even with those, nothing is on a timeline.
Yeah, exactly. And I think that's probably the key take home from this entire podcast. Sinead, there will be people who are literally listening to this and going, I definitely need Dr. Sinead Dufour in my MDT right now. How would they get in contact with you if they wanted to do that?
Yeah, probably the best way to get in contact with me is either DM me through Instagram. You can connect with me through my McMaster Experts page. All of my research is there, but my contact information is there. Those are probably the best ways.
That sounds great. Sinead, I cannot thank you enough for coming on. If you're out there and you are working with athletes, please go and check out all the resources that the FIFA Female Health team have put together because they genuinely are excellent. And as Sinead has highlighted, they are open access and they are free. We will see you soon.
Thank you for listening to Women's Football Hub. The information within this podcast is for informational purposes only. No material on this podcast is intended to be a substitute for medical advice, diagnosis, or treatment. Please contact your doctor or another healthcare professional if you have any questions about anything raised in this podcast.